Hello, everyone. Welcome back to Karan Academy. My name is Karan. I hope you all are doing really, really well. Today, we're going to be talking about peptic ulcer disease and gastric cancers and a few other types of cancers of the GI tract and why they're important. The first part's very high yield. The second, not so much, but I think it's still important. Okay, so let's jump right into it. So also, I realize I keep saying let's jump right into it, and it's really starting to annoy me. But it's kind of a reflex. I don't know what to do at this point. Okay, so what is going on with peptic ulcer disease? You know that your stomach has a protective layer, and you know that it produces acid, and across your life, there's going to be a constant balance between the two, one trying to destroy the other. And when your protective barrier loses, that's when you have a peptic ulcer. A peptic ulcer can either be kind of an ulceration or an erosion, depending on how severe it is and how deep it goes into the mucosal layer. An ulceration tends to be a bit more deeper than an erosion. Erosion is more superficial. It is relatively common with the lifetime prevalence about 10%. And you can obviously divide them into gastric and duodenal ulcers depending on where they are. And we'll talk a bit about how the two present a bit differently and are caused by different things, broadly speaking. So the risk factors are alcohol use, smoking, NSAIDs, steroid use, and H. pylori, and this condition called Zollinger-Ellison syndrome. So let's talk about why each one is kind of a risk factor for these conditions. Before that, let's talk about the defense mechanisms, because obviously we have a failure or an imbalance. So what's going on here? Firstly, we have a very, very high rate of turnover of the gastric mucosa. This is to basically replace any cells that have been damaged and replace this with healthy tissue. Secondly, we have tight epithelial junctions to prevent the seepage of gastric acids to the submucosal tissue. You also have a layer of bicarbonate or a more basic medium, which neutralizes the acid and prevents injury. And lastly, you also have the duodenal cells producing a chemical called somatostatin. Now, what somatostatin does is it inhibits gastrin and therefore reduces gastric acid secretion. The normal role of somatostatin is in kind of stopping gastric production when you've already eaten food. So the way it works is when you eat food, and by the time the food reaches the duodenum, that's kind of when you don't need any more gastric acids, right? So that the duodenal cells are activated to produce somatostatin. Somatostatin blocks blocks gastrin, and blocking gastrin would reduce gastric acid secretions. So how does this fit into kind of our grand scheme of things? So firstly, we have NSAID and steroid use. So NSAIDs and steroid use disturb the bicarb mucinous layer, and therefore, once you lose that layer, it's going to be easier for the gastric acids to cause damage. Next, we have H. pylori, and this is a very, very big one. It's a bit harder to figure out why. It's a bit more than 2 sentences, and that to me is hard. So H. pylori very typically colonizes the duodenum and not the actual stomach. This is also the reason why the leading cause for duodenal ulcers is H. pylori, and 95% of duodenal ulcers are caused by H. pylori. What H. pylori does is a few things, and one of them is inhibiting the production of somatostatin. As we know, somatostatin blocks gastrin, and when you reduce the levels of somatostatin, you have higher levels of gastrin. Higher levels of gastrin lead to more acid production and release, and that leads to the ulcers. It is also for this reason that H. pylori infections can typically present with GORD. Now let's go back a few slides and talk about these other ones. Alcohol use. Well, alcohol is a natural irritant and can lead to both peptic ulcers as well as chronic gastritis. Smoking, because smoking is a risk factor for everything. We've already talked about this too, talked about H. pylori. Now, what is Zollinger-Ellison syndrome? Now, Zollinger-Ellison syndrome is a very interesting one because it's not very commonly talked about, and I think it's an interesting one. So what happens is Zollinger-Ellison syndrome is a neuroendocrine tumor affecting the pancreas. So it's a tumor found in the pancreas, and what it does is it releases the enzyme gastrin. Now, we just talked about the role of gastrin, and gastrin increases gastric acid secretions. And therefore, if you have a tumor that's secreting higher levels of gastrin, you're going to end up with a peptic ulcer and potentially GORD. So we're going to go back to some basic anatomy and talk about different parts of the stomach and why that's relevant. So we have four main parts: the cardiac, the fundus, the pylorus, and the body. In terms of ulcers, they tend to usually happen either along the lesser curvature or in the pyloric antrum. You have three layers of muscle: the outer longitudinal, inner circular, and then the obliques. Arteries are really important to know because a big concern with peptic ulcers is as they erode through the mucosal layer and through the muscular layers, if they pass the serosa, they can actually invade into arteries. And a perforated peptic ulcer with a bleed is really, really bad. And we have a whole other lecture dedicated to upper GI bleeding. So I won't talk about bleeding peptic ulcers here or how to manage them, but we do get to it later. So I've just mentioned the arteries very briefly at the lesser curvature. So here we have the left and right gastric arteries. At the greater curvature, we have the gastroomental arteries. With the fundus and the upper body, we have the short and posterior gastric arteries. So you could get a potential question as to what's the most common artery likely to be affected. It's probably going to be the gastric arteries as it invades through the mucosal layer. Okay, so how are gastric ulcers different to duodenal ulcers? Gastric ulcers tend to be mostly NSAID and steroid linked. The way I like to think about it is, well, you consume steroids orally, and NSAIDs orally. The first place that they're going to hit is going to be your stomach, not your duodenum. Right. We also talked about how H. pylori typically colonizes the duodenum. Duodenum. I don't know if I'm saying it right, but you know what I mean. And 95% of duodenal ulcers are linked to H. pylori infections. Next, we have the association with food. And this is a good one to know because it does come up on exams sometimes. Gastric ulcers typically get better with food. The reason for that being when you eat food, it kind of prevents more action of acid on the ulcer itself, and you get a bit of symptomatic relief with the epigastric pain. And duodenal ulcers get worse with food. The way I like to think about that is you're eating food and you're going to start releasing high levels of acid, right? So just as you're eating, the food is going to come in the stomach and cover the ulcer, and the ulcer is a bit less painful. But as you're secreting acid, the acid is going to go down. And if you have a duodenal ulcer, it's going to make it significantly worse. And on that same line of reasoning, as the food then gradually moves down, the duodenal ulcer gets a bit better and gastric ulcer gets worse. So gastric ulcers worse between meals, duodenal ulcers worse usually with food. In terms of the bleeding, also posterior perforations of the gastric ulcers, important to know, can lead to ruptures of the splenic artery, and that's a very, very vascular structure that can lead to massive hemorrhage. And then with duodenal ulcers, the one we worry about, is the gastroduodenal artery, and both of them can lead to upper GI bleeds. In terms of investigations, we won't bother with bedside investigations for this moment. Let's go to our definitive tests. We have the urea breath test and the H. pylori stool test. So I'll talk briefly about what the urea breath test is and how it works. So the urea breath test looks for H. pylori. H. pylori has an enzyme called urease, and urease breaks down urea. So what we do is we give these patients urea to basically inhale. If there was H. pylori, the H. pylori would break down the urea. Now, what's special about this urea is that it's tagged with radioactive carbon, so C13, not C12. And you obviously produce a different kind of urea. So once this breaks it down, the two byproducts of urea are ammonia and CO2. And therefore, when you exhale, you're going to be exhaling those two compounds, right? So what you can often do is you can look at the bag and then you can look at the CO2, and the CO2 is going to come from one of two places. It's either the CO2 you're breathing out or the CO2 that's come from breaking down urea. And then you can distinguish the two, because remember, we said that the urea, or the carbon of the urea, is C13, which is radioactive, and it's a radioactive isotope. And therefore, you can tell what percentage of the CO2 that they've exhaled is coming or is composed of radioactive CO2 versus the normal CO2 that you breathe out anyway. You then also have the H. pylori stool antigen test, which is a other test you can do. The gold standard is obviously doing an endoscopy and a biopsy. A biopsy typically shows necrosis and inflammation. We can often look at the degree of inflammation as well, and the degree of invasion, which can be important sometimes. And one of the big complications we worry about is bleeding and perforations. Oh, sorry, it's getting really late. So if you suspect a bleed or a perforation, you should also always consider the following tests. So an FBE and iron studies. So an FBE, because they might be anemic, especially with acute bleeds, our degree, how aggressively we want to replenish their hemoglobin depends obviously on their hemoglobin. So anything less than 70 is quite concerning. And then with iron studies, well, if you have something that's more chronic and a slower bleed, you can have chronic iron deficiency anemia. Serum urea is really, really good for acute bleeds. And this would be part of your urea UEC screen. So urea, electrolytes, and creatinine. So as you know, urea can go up with chronic kidney disease as well. What's special about upper GI bleeds is that in those cases, you see a high serum urea, but a normal creatinine. You can also then do a chest X-ray looking for a pneumoperitoneum, which would present as air under the diaphragm. Our management is going to be based off our detailed history and the investigations we performed. If we suspect that the ulcer is gastric, and we suspect due to medications like NSAIDs or steroids, we would try to modify steroids or their medications into something that's going to have less of an effect on the gastric mucosa and provide medications that are less irritating. And if we can't do that, we would always prescribe a PPI to go with that to reduce the level of acid secretion. If the ulcer sounds like a duodenal ulcer, which most of them do, the most likely cause is going to be H. pylori, and therefore we are going to try and treat H. pylori. We do that through a triple therapy of amoxicillin, clarithromycin, and a PPI like esomeprazole or pantoprazole. If we try this for a few weeks or a month and we repeat the urea breath test or the antigen test and we don't notice a change, we might consider resistance to the antibiotics we've given, and therefore consider quadruple therapy, which is again a PPI, but now 2 antibiotics and a bismuth salt, which increases the efficacy and prevents resistance. Now let's talk about gastric ulcers. Now, gastric ulcers, as you can see on the left here, it's a nice pretty lesion eroding into the into the lumen, is the 5th most common cancer. It mostly affects older men. And the risk of gastric cancers is double in men compared to women. These are mostly adenocarcinomas from the columnar epithelium because, well, that's what most of the gastric mucosa is going to be anyway. You're not going to find much squamous cell tissue here, are you? In addition to knowing just that, there are a few extra cancers of the GI tract presenting with, or cancers of the stomach, which present similarly. These can be lymphomas or maltomas or non-Hodgkin's lymphomas as well. You can have gastrointestinal stromal tumors or GISTs and neuroendocrine tumors. We talk all about these in a bit. But before that, let's talk about a few risk factors. So age, male sex, family history, H. pylori, smoking, gastritis, pernicious anemia. So let's go through each one of them and talk about why they're a risk factor. Age and smoking, I don't think it takes me I don't need to tell you why age and smoking and family history are a risk factor. Male sex is more so just something that's found potentially as a confounding aspect to smoking and drinking. There could be a actual genetic link, but I'm not quite sure about that. With H. pylori infections, you have long-term periods of inflammation because of the infection. So step one, you have an infection that causes inflammation. Step two, H. pylori specifically can cause gastritis and peptic ulcers, and those further have high levels of inflammation. Then you can have gastritis for a bunch of reasons. Gastritis, as the name suggests, is inflammation of the gastric mucosa. The more inflammation, the more the risk of malignant conversion. And then pernicious anemia, which is an autoimmune condition. And with autoimmune conditions, you could have long-term levels of lymphocytic inflammation, and that again predisposes you to cancers. The symptoms often depend on how invasive or how progressed the disease is. So your general cancer symptoms are going to be weakness and weight loss, but then we have a few gastric specific things. So let's go through this. The first one is chronic iron deficiency anemia, and this can be because of a few things. Firstly, you can have decreased levels of absorption, and that is going to be primarily because you have now inflammation and improper mucosa, and that's going to prevent adequate levels of absorption because you need gastric acids to help with iron absorption. Then you have dyspepsia. Dyspepsia often is, so dyspepsia is just irregular or inadequate or improper gastric acid secretions. You can have GORD because of the same reason, epigastric pain because of compressive symptoms, a palpable mass if it's really big. Again, if it's big and it's invading on the gastric outlet, you can have dysphagia and nausea, vomiting, because you kind of have a pseudo obstruction, or actual obstruction, but it's not your small bowel obstruction that we typically see. You can have upper GI bleeding because these lesions are quite friable and predisposed to bleeding, which could present as hematemesis or melena. And then with progressive disease, usually stage 3B and after, you can have metastatic spread with hepatomegaly, ascites, and left subclavicular lymphadenopathy, which is called a Virchow's node. And we've talked about this in our respiratory section. In terms of staging, it follows a very, very similar disease progression, much like many other cancers. So you have high levels of inflammation that predisposes you to a dysplastic change. With the dysplastic change, you then get carcinomas in tissues, which progresses on to more progressive disease. Once we invade past the in situ phase, we have the T system of classification. So T1 is when it's confined to the broad mucosal layers. So it can either be T1A or T1B, depending if it's mucosa or submucosa. T2 is the muscular lamina propria layer. T3 is serosa, but not past the visceral peritoneum. So it's still within the stomach technically. And then T4 is beyond the visceral peritoneum, spread elsewhere. Obviously, this doesn't tell us how aggressive or microscopically aggressive the tissue is. And therefore, we always like to grade the tumor as well. And this is done microscopically through a biopsy, which can be the low or high grade. Nuclear mitotic activity, it should say. A few other important things to know. This thing called linea plastica pops up quite a bit, and that's a leather bottle appearance due to widespread adenocarcinoma. That has a really bad prognosis. Sorry, I should have put a picture in, but if you have a look, it just looks like the entire gastric mucosa is ulcerated and charred, and it's basically advanced disease. You then have maltomas, right? Maltomas or malt lymphomas are highly linked to H. pylori because of that inflammatory process I talked about. And although the term malt lymphoma sounds a bit kind of bad and scary, they actually have a generally good prognosis. So if you eradicate H. pylori itself, you can have a relatively good outcome. Obviously, if the disease has progressed significantly, that may require a gastric resection, depending on how invasive the tumor is. But most cases, good prognosis. Also, sorry, I didn't mention this earlier, but MALT stands for mucosa-associated lymphoid tissue. So whenever you have a mucosa, you often have lymphoid tissue around the mucosa. And now you have a lymphoma arising in that lymphoid tissue. I mentioned earlier that most cancers are adenocarcinomas because you have mostly columnar epithelium, but I lied when I said there's no squamous epithelium, because there is, but it's very, very little, which is why squamous cell carcinomas are very rare, but poor prognosis. And then you have GISTs. I actually saw it just the other day, and these are cancers that arise from the muscular tissue around the GI tract, commonly linked to genetic predispositions, and you treat them with a resection. They quite commonly have a mutation with the tyrosine kinase gene, and therefore tyrosine kinase inhibitors like imatinib can be used if the tumor has that particular mutation. Small tumors, which is less than 5 centimeters, have a low risk of recurrence. However, as you can imagine, bigger the tumor, higher the risk of progression. In terms of treatment for gastric cancers, again, depends on the stage. Anything 2 and below, we aim for curative therapy, which is mostly surgical. Stage 3, intermediate, stage 4, palliative. In terms of our surgical approach, really depends on how aggressive and how widespread the tumor is. If it's just a stage 0 in situ or stage 1, we can do an endoscopic resection. Anything 1B and beyond, 1B to kind of 3, we opt for a total gastrectomy and lymphadenectomy. And this is kind of the best or the most appropriate procedure for this. You can also do a subtotal gastrectomy and a Roux-en-Y gastric bypass, but that's not very commonly done. So our broad options are either an endoscopic resection or a total gastrectomy. In terms of medical therapy, again, as with any cancer, I'm going to say that they may also require adjuvant chemo and radiotherapy. And as I mentioned earlier, if the tumor, sorry, I didn't mention this earlier, but some gastric adenocarcinomas are HER2 positive. And if they are, we can use trastuzumab, which is a monoclonal antibody. And that's the end on our lecture on, what's the lecture on? Peptic ulcers and gastric cancers. Oh, am I tired? Thank you all for coming. As always, if you have any questions, feel free to check me a message. I'm more than happy to answer them. And as always, please look after yourself and please look after your loved ones.